Hello and welcome to today's virtual panel discussion on the current and future state of telehealth. I'm Carol Flagg of Answers Media Network. Thanks for joining us today. This event is a virtual roundtable with industry leaders sharing their views and insights on the seismic shift in moving telehealth from a point of very low utilization to a primary means of providing healthcare services during the COVID-19 pandemic. What will be the lasting impact of this shift on providers, payers, and patients as the pandemic abates? And is the more widespread use and adoption of telehealth services and technologies here to stay? Our panel of experts are here to address these questions and more as we spend the next 75 minutes discussing telehealth. Before I introduce our moderator and panelists, I want to thank our sponsor of this event, MediVisum. MediVisum provides HIPAA-compliant, on-demand video conferencing solutions that enable providers and healthcare practitioners to conduct personal, face-to-face interactions with patients remotely. Their solutions enhance the efficiency and effectiveness of any practice and enable providers to extend care beyond the walls of their practice. Learn more at www.medivisum.com. Our moderator for this event is no stranger to virtual panels. Matt Fisher is a partner and healthcare specialist in the law firm of Myrick O'Connell. He also hosts a radio and podcast show, Healthcare du Jour, on our own Healthcare Now Radio network. Matt advises clients on regulatory issues, privacy, security, fraud, abuse, and compliance, and includes structuring contracts, affiliations, agreements, and other business arrangements to meet both federal and state statutory and regulatory requirements. His regulatory advice focuses on complying with requirements of HIPAA, the Stark Law, anti-kickback statute, fraud, abuse, licensing, and requirements related to the Medicare and Medicaid programs and the Sunshine Act. He also advises clients on compliance policies to develop appropriate monitoring and oversight of operations, and advises healthcare providers of all sizes, as well as digital health and health IT companies. Our first panelist is Rob Tennant, who is the Director of Health Information Technology Policy for the Medical Group Management Association, better known as MGMA. Rob has participated on several of our panels over the years, and we're thrilled to have him back with us again. At MGMA, Rob focuses on federal legislative and regulatory health information technology issues and is involved in numerous industry associations to drive policy, including the Board of Directors for the Work Group for Electronic Data Interchange, or WEDI, and WEDI's Strategic National Implementation Process, the eHealth Initiatives Policy Steering Committee, the Council for Affordable Quality Health Core Initiative, Healthcare Administrative Simplification Coalition, and other national entities. He began his work with MGMA in June 1997, holds several degrees, and is a recipient of the WEDI Distinguished Service Award and Leadership in Technology Award. Allison Armstrong is a health policy director at Anthem in the Public Policy Department. After completing her master's degree in public policy at Pepperdine University, Allison joined Anthem's Regulatory Compliance Department, where she managed regulatory activities, implementation, and compliance for Anthem's West Region states. In 2010, she moved on to Anthem's public policy team, where she represents the company on policy issues including payment and delivery system reform, prior authorization, transparency, surprise medical billing, and of course, telehealth. Allison is also the co-chair of the WEDI Telehealth Work Group. And rounding out our panel is Jim Tate. Jim is the Chief Product Officer for MediVisum and founder of EMR Advocate and host of the Tate Chronicles on Healthcare Now Radio. Jim has worked in the digital healthcare field for over 30 years and has direct experience in both clinical and technology environments. He is a nationally recognized leader, author, and radio host on the development and appropriate use of health information technology. And as founder of EMR Advocate, he has worked directly with over 300 technology vendors on their healthcare products. All right, so I'm going to turn this panel over to our moderator and panelists and go on mute and take it away, guys. I'm looking forward to a great conversation.
Well, Carol, thank you for all the introductions and welcome everybody to the panel today. It's, I think with the focus on telehealth, we certainly have a lot to talk about because I feel like we've moved past the promise stage to the actual implementation, the reality of real world usage, which is, I think, a great development. So kind of what I'd like to do is just kick it off with, allowing each of you to have, a little bit of I'd say kind of an opening statement. And to hopefully guide that a little bit, I'd say, to have you give your thoughts in terms of what you've been seeing over the past few months to really kind of tee up the discussion of the current status. And I know this is, and I know not all of us are going to have the same order, but I'm going to start with Allison, and I'm going to end up going in a counterclockwise pattern here. So Allison, you're up first, and then Rob, you'll be second.
Thanks, Matt, and thanks everybody for having me here today to talk about one of my favorite policy issues I work on. Telehealth is something I am passionate about both personally and professionally, and have been working for years at the state and federal level to try and get meaningful change to our laws and regulations to help expand access to telehealth services for consumers across the United States, whether they are getting their care through their coverage through an employer, through a Medicare Part B, or in a Medicaid plan, and recognizing that it shouldn't really be differentiated among what type of coverage you have, whether you have access to those services. So when I started working on telehealth policy for Anthem, it was back in 2013. And at that time, what my main charge was really trying to shape those commercial laws at the state level, because the beast at the federal level was, seeming like it was going to be a long time out before we could get those changes, but maybe we could get incremental changes at the state level. So over the years, we really advocated boots on the ground to make changes, and submitted comments and advocated at the federal level, and we're very passionate about removing barriers to telehealth at the federal level as well. But years and years and years of that work, slow incremental change that was happening kind of piecemeal in certain markets, and then we have today, and we had the COVID public health emergency, which accelerated and expedited everything that telehealth advocates have been asking for many years, was done within a matter of weeks. And I think to the shock and appreciation of many. So given that there were years of trying to lay the foundation to get these changes in place, and then they happened so quickly, I think now we are moving into a phase where we're able to actually look at how this care is being delivered, how it is being utilized, who are the utilizers, what are the barriers that are still existing now that we've removed many of those, and what lessons are we learning for future policy decisions. And so that's where we're focused, but we're going to have a long discussion, so I'll stop there.
So, and Rob, how about your perspectives?
Yeah, first of all, I want to echo Allison and thank Answers Media Network for the invitation. Telemedicine, telehealth has been such an important issue for MGMA physician practices, again, for many, many years. And I'll paraphrase the chairman of the Senate Health, Education, Labor, and Pensions Committee, Lamar Alexander, who said, we crammed 10 years of education on telehealth into 3 months. This pandemic has really accelerated not only the need, but the demand for telehealth. And when I look at this issue, I look at it sort of in a macro perspective, looking at what federal policy is and what it should be, especially post-pandemic. But I also look at it from a micro level. I had a telehealth visit myself with my physician. And, I'd met with him over that last 15 years. This was the first time we did it over the computer, and it was still very effective. And I will say one of the things, and we'll get into sort of the value proposition of telehealth, but we almost always talk about it from the perspective of the patient, and that's critical. But my own physician's partner came down with COVID after treating patients. So physicians are seeing the value, especially during the pandemic, of being able to be remote, yet being able to treat their patients effectively. So I'm looking forward to a discussion of not only sort of the current state of telehealth, but how this pandemic is going to shift the paradigm as we go forward. I think there's huge opportunities. I don't think it's a replacement, and I think we'll talk about that. It's not a replacement for patient encounters face-to-face, but it can sure augment that care delivery process. So again, looking forward to a good discussion today.
So, and Jim, let's round out with you on the initial impressions.
Well, thank you, Matt. I think that as far as health information technology goes, telehealth or telemedicine has been the stepchild for a number of years. We've had the technology, we've had some of the use cases, but they were very niche use cases. And then as both Allison and Rob have mentioned, we had the declaration of a national health emergency because of COVID-19 and a rapid adoption of telehealth. It was like a wave coming in, and providers and patients had to scramble to figure out how to use this technology. And just as businesses that are non-health related have had to struggle to learn how to use Zoom and other virtual platforms like this, there was an extreme learning curve that was crammed into a couple of weeks to people on both sides. Patient providers could figure out how to make this technology work. As we move through the emergency, definitely some of the issues around reimbursement, and be interested to hear what Allison brings to us about some of the reimbursement issues. But the reimbursements that have been brought up to parity with in-person visits may be rolled back. There may be certainly a rollback of the relaxation of the HIPAA requirements that have really been eased up during this emergency. And what I'd like to focus on today are some of the extremely important use cases that we have been discovered and are going to be here after the storm passes. So glad to be here. Thank you.
Yeah, and kind of picking up on, I think, a theme that went through all three of your statements. It's, you're talking about that there was this background foundation that had been built up over time, and now you got this rush to actually implement it. So given all that background kind of prep work, how have you seen telehealth actually evolving now, over the course of the past 3 months, now that we've seen such accelerated usage? And we'll go the slightly different order this time. So Rob, why don't you kick us off?
Well, I'll start by maybe looking even further back. We did a poll of our members back in 2018. We asked them how many are using telehealth services, and it was 26%, and 15% were considering using these services. In 2019, we asked the same question, and it jumped up to 29% were using and 17% were considering. Well, we did that survey in March, the end of March of this year, and 97% of our respondents said that they were using telehealth. So it is, as Jim alluded to, a seismic change in how care was delivered. And we have to keep in mind two things about the pandemic. One, we had a lot of sick folks with COVID, but there was still a healthcare system in place. People still had chronic illnesses. They still got sick with other things. They had to see their physician. They had to make sure that they were taking the right meds, that they were doing the right things. And this was really a wonderful opportunity to keep that continuity of care. And again, as a small business, the practice couldn't afford simply to shut their doors. So this allowed patients to be seen, claims to be submitted, and practice operations to continue.
So, and Allison, how about you?
I agree with everything Rob said. And what was fascinating for me was we had, for years, gone on record, stated the barriers, things that need to be changed. Here's what can be done to improve and increase access to telehealth, help providers get reimbursed. Here are all those things, but it moved at a snail's pace. What was really fascinating to me was the learning curve throughout the development of the coronavirus legislative packages. So we had 3.5 packages, and you can look at the language from the first package piece of legislation, where they tried to remove restrictions in Medicare Part B for qualified providers, but define qualified providers in such a limiting way that it was going to do very little to really increase access to Medicare Part B beneficiaries. Then you see like a week later, a new package where they change that definition a little bit, recognizing, oh, we need to account for those people that have that relationship with the provider, but just aged into Medicare. So they made another little tweak. And then by the third package, we saw the recognition that those tweaks and those smaller changes were not enough to move the needle and improve access and get to that continuity of care, because people needed to continue to be seen, providers needed to continue to be able to provide care, and there were modalities out there to be able to do it, but reimbursement policies and laws and regulations were standing in the way. So for me, that backlog of policy issues that had built up and changed, it still was fascinating for me as somebody who watches legislation all the time to see over, package 1, 2, 3, these incremental changes that just kind of blew it wide open, and that recognition by Congress that the first couple of attempts were not going to get the job done.
So, and Jim, what kind of evolution have you been observing?
Well, let me take a step or two back. First, Matt, I think a definition is always appropriate. And from my standpoint and reading experts in the field, there are really three types of telehealth. One is the what they call store and forward, where clinical information is gathered. Maybe it's patient generated. It could be lab results or radiographic images, and it's forwarded for analysis by a provider or some other healthcare entity. And then we have that whole area of remote monitoring. These are electronic devices, whether they're oximeters or blood sugar analysis devices or peak flow meters, cardiac monitoring things that gather data and send them often in real time. And this remote monitoring is not only treatment or chronic disease focus, it can also be diagnostic. An example I'll give is with COVID-19, most sleep laboratories in this country shut down immediately. A sleep apnea diagnostic test in a facility is considered elective. So those shut down immediately. So the only way they could really be done, a few are being done now, but it's been reduced over 90%, is to have home sleep studies. So you can have that diagnostic equipment delivered to somebody's home. Some of these devices are actually disposable. The data is gathered, and sleep apnea diagnosis can be made or not be made. And the third category is what we traditionally think of, that's the real-time interaction. That is, instead of a patient coming to an office for a follow-up or initial visit or episodic encounter, it's done electronically. So there's a couple different categories here. Some of these are based on reimbursement. In the question of sleep lab, the parity of what Medicare will reimburse for a home sleep study is about 1/4 of what Medicare will reimburse for a sleep study in a lab. So there are business models that exist that are going to immediately push back against the home sleep studies. It's just a business type issue. So there's going to be some movement on that side, even though it may be advantageous to do sleep studies at home, reimbursement is not there. And another thing I think that we need to talk about sometime during our discussion is when we're talking about real-time interaction, a provider with a patient who has a sore throat or has a rash and they're doing telehealth encounter, what functionality should that telehealth platform have? And so we'll talk about that in a little more detail, but I see it's not only the adoption because it's a best practice, there are reimbursement issues involved here also. And there's going to be a giant shakeout in all these telehealth platforms that have come into the market. And the ones, because of the rollback in HIPAA requirements that were immediately adopted, were really never built for healthcare documentation or privacy and security. So it'll be interesting to see how things shake out just from an industry standpoint.
And Jim, oh, sorry, go ahead, Rob.
If I can just add to Jim's list, because what we're seeing with some practices is a hybrid approach of all things, especially for those patients and those practices that are only able to do audio only. What a lot of them are doing is they're combining sort of a information flow. So for example, a dermatologist may have their patient take photos of a rash or something like that. They upload them through a secure web portal so the physician can be looking at the image and talking on the phone. So there's a lot of innovation going on, and some of it, of course, is done out of necessity because perhaps the broadband capabilities of the where the patient is located is poor. Maybe they're elderly, they're not able to use Skype or that type of platform, but there's still a way to deliver care. And I think that's one of the things that we saw certainly during the pandemic.
Yeah, and actually, Rob, I'd really like to explore that point a little bit more because I'm interested to learn about what are the experiences of both the patients and then Rob, I think you'd already pointed this out earlier about the clinicians as well. Because I certainly agree with you. I think the way in which these tools are being utilized is being modified as everyone gets more experience with it. Like my wife is a primary care physician, so she's done a fair amount of telehealth over the past couple months. And, one of her observations is I can actually see into the patient's home, which kind of gives other clues in terms of what's going on. So that's one area where I've, obviously one anecdote, but I think it's been reflected in other things that I've seen. And then I was talking with my dad this weekend, who's also a physician. He's a neurologist, and he was saying that for some of the status, the mental status exams, he asked the patient to get a family member who's nearby to help with some of the things that require interaction, and in that way he's able to do a lot more of the scope of the exam that he would require an in-person visit for, but can train up, essentially train up someone who's present with the patient to allow that remote access and probably fit in better with the patient's individual situation, at least right now. So as I said, I'd really like to I think that might be diving into some more specific use cases. And I think to be fair, I think I'm going to let Jim go first because you've had to clean up the last couple times around.
Well, thank you. Just first to kind of respond a little bit to Rob, the ability of we talked about the challenges. There's certainly the technological challenge for a provider getting used to, but then there's the technological challenge for the patient. And so if I'm a dermatologist and I have a 83-year-old patient and their ability to take a picture with their smartphone and upload that image to a portal, I don't know how, can 80% do that? Can 90%? Can 30%? So there's a ease of use or user interface, I guess, on the patient side that makes things like that as easy as possible. And so again, any platform that's going to be healthcare based needs to be so easy for patients. Another example is, a good telehealth platform. If a provider's going to have an encounter, they'll send a text message or an email, but essentially a patient clicks on the link and they're in the encounter or in a virtual waiting room. We don't want a patient to have to download an app or configure an app. If you do that, you are restricting healthcare access. So hopefully more and more is going to be done to make it easier on the patient side. Kind of back to use cases. I think that one thing that we're seeing right now because of the COVID emergency that's starting to be spoken about somewhat is there is becoming a backlog in healthcare delivery. For Medicare patients, probably who are eligible for an annual wellness visit, not an annual physical, but just an annual wellness visit, as typically done in a face-to-face encounter, either in somebody's home or at the office. tens of millions of those, I'm sure, have been deferred. So at some point, there's going to be that big hill to get over of deferred healthcare, patient checks, all that kind of stuff. And the more that can be done now is going to ease the road. And so such things as a annual wellness visit, where essentially a nurse practitioner or PA or some other provider, either by phone or video, has the ability to go through a patient's current medications and weight and things like that, can be taken care of now. So those use cases that do not have to be deferred, I think are really critical. Now, some of the use cases, I think, have to do with many of the typical office encounters. Of course, such things as if you need to be sutured, you can't do that. But there are a lot of things you can do, especially around the area of wellness visits. Medicare has eased up, as Rob was talking about, that some of these telehealth encounters, the reimbursement has been increased to be on parity with in-office visits. And on the phone, you can do one thing, but at least through telehealth, if you use the video portion and can see a patient, many providers could just look at a patient and say, "You're sick. You need to go to the emergency room." They really need to actually see somebody to do that. So I think we're going to see a lot of that, annual wellness visits. Medicare has eased up on the recertification and some of the requirements around home health visits, because anybody who's receiving home health is obviously at a heightened risk. They don't want people coming into their house. So the fact that telehealth, if there's appropriate technology for the patient side, can take care of at least some of that lifting for home health. Behavioral health. A lot of social workers and other people in the behavioral health field have jumped on the bandwagon of using telehealth. It's better in person. There's no doubt about that, but they have been able to continue to deliver care. And I think the video portion is certainly superior to just the audio only. Rehab, kidney disease, certifications for people with renal disease. A lot of these things have been eased up on in terms of what is reimbursable now under Medicare. Some of them are going to be rolled back. Something that Rob mentioned or alluded to a little bit, the area of if you're conducting a visit maybe with an elderly patient, maybe there's some cognitive issues, who knows, but the ability to have more than just the patient and provider on a call. You want to be able to, if they have an adult child in another city, have them included in the call, in the session. So I think that's important. A lot of these platforms that are being used were just kind of taken off the shelf and didn't have the ability to have multiple individuals on a call to gather as much information as possible. So a lot of use cases. I'll allude to one more. I constantly get contacted by people who are in healthcare delivery who say we have this need. Well, in sleep labs, one need that's being filled when they start doing sleep studies is after a patient has a sleep study, they usually come back and the sleep provider goes over the results of that test. Well, that doesn't need to be in person. As long as you have a good telehealth platform where you can share a screen, show some tracings, give detailed information, that really is a benefit to the patient as well as to the provider. So going over diagnostic results is a great use case. And some of these use cases are definitely going to continue. Many private practices were built on business models of having patients walk in the door and seeing 20 to 40 patients a day. And all of a sudden that stopped. So they had to immediately start doing telehealth just to survive. But they have a staff that has been built over years of clinical assistants to help patients in, to weigh them, to do blood work, things like that. So I'll defer to Rob on this. He can probably give us some indication, but the ability of these practices to try and morph back to their more standard care, but still using that telehealth in the appropriate way.
So Rob, do you want to kind of pick it up from there? Because it seemed like Jim was giving you a perfect turnover point.
Yeah, Jim did a great job of outlining a lot of the use cases, and I'll just touch on a few others. But you're right. I mean, what's interesting is even during the pandemic, we saw multiple workflows within a practice. So you had essentially three. You had telehealth, you had a face-to-face patient encounter, especially those with sort of emergency situations or critical. And you had a third, which was kind of unique, and that is what they call the drive-by encounter. So the patient would come in their car, and the PA, the nurse practitioner would actually come out to the car and do the triage right there, because the patient didn't want to come into the practice, and the practice staff didn't want a potentially positive patient to come in as well. As Jim alluded to, what is the workflow going to look like post-pandemic? There are, I think, some really tremendous advantages for telehealth, but it is not a replacement. And especially what we've heard is it's not a replacement for the initial visit. It's a much more effective tool with an established patient. When you first starting to meet that patient, usually it's a longer period of time. It's more effective face-to-face. But here's a few other, I think, really positive aspects of telehealth. And Matt, you alluded to being able to look into the patient's home. That's so critical with behavioral health, but also with pediatrics. What we're hearing is it's very effective for the pediatrician to be able to see the environment that the child is in. It can be very, very helpful to the clinician. And then there's some other areas. For example, things like wound care, where post-surgical situation where the patient is able to have the physician look at the wound, make a determination how the wound is doing, does need specific attention. And then the whole area of chronic illnesses. So you're a diabetic, you've got pulmonary issues, you've got hypertension. The best case scenario is to be able to leverage wearables and other remote devices to be able to funnel data to the practice and then have that virtual encounter and talk about the results. That can be a very effective way of making sure that the patients are continuing to get good care, and especially, candidly, as the industry moves into more value-based care, there's a tremendous advantage for the practice to kind of keep tabs on those patients, for those diabetics, to make sure that they don't end up in the ER. Bad for the patient and bad certainly for value-based care. So I think there's some huge opportunities. But I think what will be interesting to see, and again, all roads sort of are leading down to reimbursement, and how health plans, including Medicare, Medicaid, and the commercials, how they deal with reimbursement is really going to drive the dialogue post-pandemic. If we revert backwards and we're not getting paid for that type of work, I just don't see it having the same impact. But one health plan executive was quoted in the trade press as saying, the genie's out of the bottle. And it's unlikely that these large health plans are going to scale everything back. They may tweak the programs. But what we heard, for example, from Blue Cross Blue Shield of Tennessee during the HELP hearing was they're moving ahead, but they're going to let the data drive their policy. And I think that's one thing I probably will talk about a little bit later, but we have to know what the results are. Reimbursement, quality of care, patient satisfaction, all of those metrics have to be tracked and plugged in, and I think that will drive the discussion going forward.
Then Allison.
Sure. Well, from the payer perspective, of course, reimbursement and the provider perspective, reimbursement's on everybody's mind, and that drives a lot of who's going to be willing to offer it. They want to get paid for it, and who has the coverage for it. A couple of points I just want to go back to and touch on, because I couldn't agree more, is the ability to see into a patient's home. Is really, in behavioral health space, the pediatrics is a really interesting point too. But when I've spoken with, our behavioral health team, that is a critical component. But it also lends itself into the medical field as well. If you've got a patient with chronic care management and diabetes, and you can see, perhaps the food that is sitting around, how are they complying with their diet, things like that. You can learn a lot, in really looking at those other social determinants of health and how those are all also impacting the person overall. So I would definitely say that's an important piece. And when we think about that video aspect being important, I will say a big lesson learned during this pandemic with the Medicare Part B population was the reliance on audio only encounters is much greater than had been anticipated. I'm not speaking for Anthem as a payer, I'm speaking as, kind of telehealth stakeholders in general in our conversations have been surprised at the extent to which audio only was the preferred modality among those beneficiaries for a number of reasons that I think are maybe obvious to some, but maybe they don't have a smartphone. Maybe they, downloading apps, to your point, Jim, that can be, a whole extra step. You want a one-click, here you go, talk to somebody. That's a lot easier than, providing somebody with a smartphone. Maybe they've never had one before, learning how to set up accounts, download apps, integrate, do all of those things, prove to be, not as utilized a tool as we thought it might be with that population. So I think there's been, at least from my vantage point, a big shift in the recognition of audio only services and where they can be of value, specifically much more so with an established patient compared to a new patient. For an established patient or for a new patient, you really want to have that face-to-face encounter and learn more about that individual during those discussions. But perhaps, during chronic care management, ongoing visits with your regular provider, audio only in that population, is going to be a more effective tool and going to help with their health outcomes, because otherwise they're not going to go to the doctor. If they can't do audio only, maybe they're not going to get that treatment they need. They're not going to follow up. So that's been an interesting development takeaway, I guess you could say, since, and it's really caused us to think more about what services are appropriate for audio only and which ones might not be. I think a lot of some are obvious, some are more obvious, and some are less obvious. But, so I think that's going to be a continued policy debate, at the state and federal level. And again, it's all going to come back to reimbursement, and that's where it gets really challenging, because you have payers who, I would say Anthem's standpoint, since I've been working on this issue, I've been asked several times over the years, why do you care so much if Medicare Part B removes those originating site restrictions? You're not paying for it. That's not your game. What do you care? And we pointed back. It's because we want providers as a whole. We want a shift in how care is delivered. And we want that to start from whether it's the Part B providers, commercial providers, Medicaid. We think this should be across the board. And if you have that large subsection of providers kind of cut out of the game, you're really going to slow that innovation and adoption. So that's why we have, for years pushed for removing those restrictions. I'm happy to see that done. And then the last point I would make just has to do with, with what we're seeing right now. There are going to be a lot of new tools coming to the market for providers. I think everybody's trying to figure out how to get into the telehealth game. What kind of app, what kind of service can you provide to make this easier for providers, for consumers, and also for patients who have healthcare coverage. How are you going to integrate those benefits? How are you going to know where you stand in your cost sharing and get, have to pay for your co-insurance if, right now we have different rules, but, down the road, that integration of benefits, I think, is going to be really important as this becomes a more widely used mode of care delivery. And also a part of our care delivery, Rob, to your point, that's not a replacement, but it's worked into our overall healthcare delivery model. So we are making better use of our time. So physicians who don't need to see a patient in person and can look at that wound and check in a quick visit that doesn't require as much overhead or staff and people coming in and, do all your weights and documentation checks. To finding those services where, maybe for behavioral health, that modality is going to be much more efficient for some and better for providers. There's going to be a way that as payers, we need to look at how we are paying providers, how we are integrating benefits into our packages to incentivize providers, and a lot of that comes with reimbursement, incentivize providers to manage care and incentivize patients to use these modalities and really work it into an overall care structure that is not so piecemeal. It shouldn't just be its own little modality off to the side. Telehealth should be integrated into the delivery system and how we address people's needs.
So since all three of you have gone in the direction of reimbursement and kind of the last part of the discussion, I definitely, and it's kind of, I think one of those elephants in the room, because arguably that was one of the big barriers towards not having more fully adopted all these different modalities of telehealth before, because if you use it and you're not going to get paid, it's a very large disincentive, especially if it means, foregoing an in-person visit where you would have been reimbursed. So Allison, I'll kind of kick it back to you first, and it's, kind of to tee it up a little bit more, it's, I think, I'm not sure which one of you kind of referenced this, or maybe it was all three of you, but that fact that at least during this public health emergency, for a large part, you've got a parity of reimbursement where Medicare and a lot of the states have forced or pushed commercial and Medicaid to do this as well, but to just reimburse at the exact same amount as if it was in the office. What benefit have you seen from that? And then, as you were just talking about, the design of benefit packages and the design of plans, how, understanding that you can't necessarily speak for Anthem and that you're probably just looking at industry trends, it's, where do you see those designs going as we transition to recognizing, or hopefully recognizing telehealth as a permanent part of the continuum of care?
Sure. I'll speak from my perspective, not necessarily Anthem's perspective, but when I think about, reimbursement parity and tying rates for telehealth to the in-office visit during, a time where we as a nation have faced unsustainable rising healthcare costs that go up and up and up. And we've seen the macro legislation and the quality payment program come about to try and shift from a fee-for-service world into a value-based care environment. And then you see large payers like Anthem and United and others, coming to the table and really shifting our contracts with providers to those that reward quality, versus volume, reward outcomes and keeping, having better care management and having shared savings, having shared losses. So when I think about reimbursement parity, starting from where we are today and looking for the future, I think it's a little premature, or maybe not the right step, to say, let's just go ahead and tie everything to this old fee-for-service structure that we've been utilizing when all we've been doing is trying to shift to value-based care. And what I'm really hoping to see is that those value-based contracts that can reward a provider for the care continuum they have for their patients, you know? So if they need to see them in the office versus via telehealth to check in on them through the duration of their episode of care, then tying that back to an old antiquated fee-for-service that a lot of folks have said, you know, is driving up healthcare costs might not be the right way to go. So I would like to evaluate a more robust way to integrate telehealth into care delivery that doesn't just say here, in-office telehealth and try and make apples to apples, because it's not.
So, and Rob, how about your perspective?
Yeah, you know, it's a tough one. And I'll broaden it out to say that, you know, if you go back in time, not that long ago, you know, there were geographic restrictions. There were restrictions on where the physician had to be to deliver the telehealth service. Those have been waived. And I think we've seen, again, this wave of services being performed, a lot of it from the physician's house. And so that's been a positive thing. When you look at reimbursement and you could say, well, why should we pay the same for a telehealth visit when you don't have that triage, you don't have, quote, those practice expenses. But those expenses still exist. The practice still has to maintain the operations. Again, if it was 100% telehealth practice, you could argue that practice expenses would be considerably less. So I think we're looking at a couple of things. One, parity is positive because we're still treating the patient, we're still delivering the care, regardless of whether it happened face-to-face or through a telehealth mechanism. But the other big macro issue is, what does this do to overall health spending? So, for example, we've talked here on the show about being better able to maintain the quality of healthcare for patients with chronic illnesses. You may spend a little bit more on the front end. You may have more encounters, for example, via telehealth with that diabetic. But does that lead to fewer hospitalizations? One hospitalization could be tens of thousands of dollars compared to much, much less for a series of telehealth encounters. So I think we're going to want to see the data. We're going to want to see if being more tethered to the patient, being able to get more information from the patient, be able to deliver more care to the patient on the front end, does that lead to decrease costs on the back end? And of course, this is going to be driven a lot by Medicare spending, but also by Anthem and the other large health plans. They're looking at this. I'm sure, Allison, you guys are looking at this. What is the impact? Is it positive? Is it negative? This exact issue was brought up at the Senate Help hearing a week ago, where they're looking at, do they know what the big picture is here with reimbursement? And I think, Senator Cassidy, who's a physician, talked about, well, with telehealth, I can lock myself in a closet with a computer and I can send all my staff home for the day. Well, that can work in some circumstances, but not all. So I think the jury's out, but I suspect that we will see higher quality care and ultimately lower cost care if we have a better relationship, more effective relationship with the patient.
And Jim, what's your take on the reimbursement state?
Sure. I think one area that since the emergency has begun has been not emphasized as much as the actual telehealth encounters, but in time may be more important, and that is remote patient monitoring, chronic care management. Patients who are diabetic or have congestive heart failure or some other chronic disease, hypertension, the ability through electronic devices to see if their values are kept within normal limits and get on top of any situation before it arises, has the opportunity for amazing savings. So if a patient has an electronic scale and they have congestive heart failure, and if they step on that scale once a day and the software is set up so if they gain 3 pounds in 1 day or 7 pounds in 3 days or whatever, an alarm is set off to whoever is overseeing that chronic care management. The ability to intervene early when somebody's getting off track before they have to go to the hospital, the ability to save money in healthcare is just gigantic there, as well as it's just much better healthcare to intercede early. Now, whether there'll be sufficient reimbursement, we've got some for years some reimbursement around for hospitals if they can keep patients with who've been diagnosed with some of these diseases and they're discharged, and if they don't get readmitted for 30 days, however you can keep them at home and keep them stable, there's some compensation for the hospitals. But the great tens of millions of people with 3 or 4 major chronic diseases, to be able to monitor them closely has opportunity for gigantic savings. And so the reimbursement for those savings has not been at the level, and it's not being mandated right now because we're just trying to put out a forest fire. And so parity has been brought up for the episodic care. So it's going to be fascinating to see if there is a willingness to provide reimbursement on the front end that will, as a slam dunk, will save money on the back end. Time will tell on that. It'd be interesting to hear what Allison says. I mean, you track reimbursement pretty closely. Do you think there's a chance that reimbursement for chronic care management, I don't mean the current CMS $40 or $47 a month. I mean, for patients really have chronic diseases and need some devices to track them.
Yeah, we had a WEDI conference a few years ago, and we had Dr. Peter Rasmussen come out from Cleveland Clinic, who talked about a remote patient monitoring pilot program that Cleveland Clinic was doing. It was managed by 2 physicians and 5 RNs, managing a population of 500 people for congestive heart failure. And they had incredibly improved outcomes with that population with this remote patient monitoring program. And I think when you have reimbursement came up and in that session, like, who's paying for that? He's like, well, we're Cleveland Clinic's paying for it, for the devices, we're paying for the program, because we need to establish and prove that it works. So then the payers will jump on board and say, we'll start giving everybody these devices. So I think that's one of the issues you run into is, between the payer provider side, or, where you have these pilots and these things happening, is, those who are going to commit to long-term reimbursements want to say, okay, well, show us it works, and then, we'll come to the table and talk. So I think there's some of that going on for sure. But I would say, from Anthem as a payer as a whole, really looking at that care continuum, the whole person care, and telehealth and remote patient monitoring and improved outcomes are fundamental to lowering healthcare costs and improving the health of our members. And so I would, I think that's what we're looking to a lot is looking for validation. I think we have that now from a lot of programs in the market. And I think when you can show big payers like Anthem that these programs work, I think you see a shift and then get on board and reimbursing and incentivizing providers to participate in programs like that. Anthem has a whole new digital health team and a bunch of pilots underway as well. So there'll be lots of exciting stuff to come out in the future. And Rob, I saw you wanted to.
If I can just add, maybe change the paradigm slightly and talk about it from the patient perspective. It's a little bit like if I said to you, okay, once the pandemic is over, now you have to put down your phone and call the airlines to try to find a ticket to travel. We're so used to using our smartphones, our apps, to be able to, to say, oh, we're going to go backwards and now you're not permitted to use any telehealth services. It's going to be a tough sell to the consumer. And I think that some of the pressure is going to come through the employers who are going to be looking for telehealth coverage when they go shopping for their employees. And if you think,
Absolutely.
and when you think about it from a patient's perspective, Jim, you talked about, if you've got a chronic illness and you've got to go in to see the doctor 3 times in the week, that's 3 days out of work. It may be a half a day, it may be a few hours, but it's decreased productivity for the employer. It's tough on the employee. To be able to close your office door and have a conversation with your physician for 20 minutes and go back to work, I mean, that's an easy sell to the patient. Nobody likes to take time away from work just to go sit in a waiting room to be seen. And, we're seeing some of the data, albeit fairly early, but we're seeing some of the data come out from some studies. One said that 91% of seniors were really happy that they had access to virtual care. And that's seniors. And we talked about maybe they are not as sophisticated or as technically savvy. I think they're more savvy than we give them credit for. And I think
they're using the telehealth for sure. Yes, they do.
And I think of my mother-in-law who had typically 5 office visits a week to different specialists. I mean, it would have been wonderful. And Jim, to your point, to be able to be on a virtual call with a physician, much better coordination of care. So the caregiver knows what Dr. A, B, C, D, and E are talking about. And so there's so many value points from the patient's perspective. I just think that that's going to be one of the drivers forward.
So actually, kind of this discussion around reimbursement surprised me a little bit because I think all 3 of you are focused more on that this can be a real driver for overall change within the industry. And, kind of Allison, as you were saying, it's, can help with hopefully a continued push in the value direction, because we should use this, or this can be viewed as an opportunity to kind of break out of the traditional fee-for-service mold. So, I think it came up a little bit earlier in terms of, already starting to shift focus towards post-pandemic, which, arguably it's really unclear when that will happen. I guess I'd say, as we start shifting into the reopening of physician practices and healthcare facilities, which is clearly happening in a lot of the states, if not every state across the country, kind of how should care be redesigned, and what steps would be needed in terms of kind of permanent legislative and regulatory change? Because we were talking about earlier, but a lot of the opening up of access to this remote style of care was purely the result of emergency orders issued under the public health emergency. And if you come from a strict legal standpoint, once that PHE goes away, with a snap of your fingers, you're back to how things were, because the only authority for the change was that declaration, the PHE. So I know that's kind of combining a lot of different things, but it's really, kind of wanting to get all your thoughts in terms of, how can this be used as an opportunity for redesign of the system, and to achieve that goal, what work is going to be needed from all interested parties? Because I really do think it'll take the physician and clinician community, the patient community, certainly legislators and regulators, and probably a whole host of other people. So Rob, do you want to kind of kick us off on that discussion?
Yeah, and I look at it sort of as a terrible analogy, but sort of 2 phases. One is the phase as we're moving out of COVID, because what we're seeing is already a lot of practices are transitioning sort of, quote, back to normal. They're seeing a lot of patients in face-to-face encounters. They're keeping telehealth. It's an option, especially for patients who frankly are not comfortable. They don't want to come into the office. So that's been a boon. But I mentioned the 97% figure early in the pandemic. That's dropped dramatically. I think still patients, a lot of them want to be seen by the physician. The physician wants to be doing that face-to-face encounter. So there needs to be sort of a glide path out of the pandemic. And I will mention Senators Blackburn and Cruz introduced legislation that would permit Medicare to support telehealth for 180 days post-pandemic, sort of that glide path out to make sure that it wasn't a hard stop and everything ground to a halt. Once we get past, and God only knows when that's going to be, but once we get past the pandemic, I think we'll come up, and I think, Allison, you mentioned earlier, we'll come up with a way that sort of meets both needs, the provider and the payer. I think it's not going to replace care, but it can augment it. And for certain specialties, for certain types of care, I think it's here to stay. And I think it's going to be a very valuable part of how a practice delivers care to patients.
So Allison, that kind of turns the ball over to you, and then Jim will have you follow up after Allison.
Sure. I think first and foremost on the other side of the public health emergency as we move forward, on the other side of this, there needs to be a level playing field, and consumers need to be able to access care via telehealth, regardless of who's paying for their care, whether it's, CMS or, Medicare Advantage, Medicaid, whatever. It's just silly this day and age that you can't have that kind of level playing field for folks. And I think right now, what's really going to be imperative, especially in the Medicaid space, because that's where we've had to do a lot of activity and advocacy during the emergency, was to get waivers in the Medicaid space for providers to be able to offer telehealth across state lines. And that was a huge barrier. And we had to go state by state by state and explain to the regulators, here's why you need to submit a waiver. And, think about the border region in a state, and the person goes to their doctor across in the next state, because that's the closest physician. That's who they see in person all the time. And now they want to see them via telehealth, and they can't because they're across state lines. So getting those kinds of burdensome barriers and laws and regulations out of the way is really going to be imperative for that level playing field, because you can take action at the federal level, but states are going to still have to take action as well to make things permanent, to make those waivers permanent, and to recognize that that's an entire population of people who can really benefit from telehealth, and especially in behavioral health services and others. And so that's one area I think that there's going to be a lot of work that still needs to be done that I don't hear getting as much focus as far as what the next steps are going to look like. We're all talking about Medicare originating site restrictions, make the home an originating site permanently, allow that. But I think we still need to do a lot of work and focus on the states after the end of the public health emergency, so that we can move forward with a level playing field for people, and eventually integrate telehealth care into our regular care delivery system, hopefully with better outcomes and lower costs.
Yeah, no, I fully agree with you, Allison, on the state level, because it's very easy to overlook that. But as you mentioned, there are a lot of issues to overcome that do require state action, in particular on the licensure front. But Jim, kind of, what's your take on the design?
Sure. I think one thing that we've seen, because the adoption, the ramp, I don't even know, call it a ramp of adoption, because the adoption was straight up. And so within the first month of the emergency, all these workflows had to be worked out. Many practices take years to adjust and fine tune and polish their workflows, whether it's the way they do referrals or the way they schedule patients or whatever. But all of a sudden there was a need to figure out these workflows, who's going to do the telehealth calls, how are patients be interested here. Rob says about this in a few minutes. One of the best practices to educate your patients that you do telehealth, and you're going to continue to do telehealth, and what they can expect and what's appropriate for the what type of encounters are appropriate, because this whole model has been based on physical closeness for encounters. And that was shattered, I guess, in March. It's when that happened. And so I was frankly surprised after watching CMS and HHS go through years and years of initial rules, and then public comment on rules, and then final rules and revisions to rules. It takes years and years around maybe the certification of electronic health records or the meaningful use program. It was at a glacial pace. And so suddenly in 1 month, as Allison referred to earlier, to get a couple of these waves of massive change around reimbursement and what was allowable. And nobody could have ever imagined that HIPAA would be relaxed. But that's what you do in an emergency. But I mean, HIPAA was like gravity. That's what everybody always said. Is this HIPAA compliant? All of a sudden, one day, somebody opened up, the stone tablets and said, well, don't worry about HIPAA too much right now. We'll let you know when to start worrying about it again. We never thought that would happen. And so I'm sure that HIPAA relaxation is going to be tightened back up. It's going to be fascinating to see what happens with reimbursement. I certainly don't have any inside knowledge, but I think we're going to continue to see parity on a lot of these things, because I think the benefit's been proven, especially to providers. So Senator Alexander in Tennessee, there are a lot of practicing physicians who are in Congress who see the benefit of this. The back end, we're not at the back end yet, but it's fascinating to hear you say, Rob, that there's going to be a glide path once they say the emergency's over of a possibly 180 days before there's any changes, maybe in regulations around and reimbursement, things like that. That's good news. I hadn't heard that. So it's good to know that, because if there are any big surprises, adjustments can be made on the provider side to adjust, because they certainly didn't have it on the front end. It was a real scramble there. And many practices just picked up any technology, and they were allowed to pick up any technology to immediately start using. So,
just to clarify, I will say the Blackburn cruise has just been introduced, so it's not quite passed yet. But I will say, sort of more importantly, there was a bipartisan group of 29 senators that sent a letter to congressional leaders saying that we want the changes that happened with Medicare to be permanent. So when it's bipartisan, it's vastly different, I can assure you, in Congress. There's, but also I keep quoting Chairman Alexander, because he's very thoughtful on these issues. He also said during the hearing that Congress has to act fast. It has a very short attention span. And if we go too much further past the pandemic, the attention span will be focused somewhere else. And so he feels, now, of course, he's retiring later in the year, so he has a vested interest in this, but I think he's correct. We have to move quickly to get something done at the congressional level.
Yeah, and I would definitely agree with that, and especially on the need for quick and prompt action because of the short attention span. Because you can be sure that there's going to be some other major issue that's going to pop up that's going to take precedence. And I think any sort of delay, because personally I'm not very much in favor of that glide path bill of the 6 months, because if you do that, they're going to assume that they did their job, and it's going to be that much harder to get coordinated action. And Rob, as you said, it's great to hear that there is bipartisan support. I think I would always just tend to take an overly pessimistic view of these things nowadays, especially in an election year where it seems like neither party would want to give the other party the opportunity to tout any type of major achievement. I'm very hopeful that I get proved wrong on that statement, but it's it's very perilous, kind of from my perspective, why, and which is why I think, kind of, as all of you have kind of implicitly said, it's, it's going to take pressure, and it's going to take a groundswell, I think, from all the interested parties to say, we want this change permanent, from patients to physicians and facilities and everybody else. But kind of, as we're already really getting close to the end of our time together, I want to give all three of you a chance to leave us with a few parting thoughts. So in interest of fairness, what I'll do is I'll go in reverse order from how we started it off. So Jim, you get to lead us off on the final thoughts.
Well, thank you. It's been great to be here with you, Matt, and with Rob and Allison. I think telehealth, the explosion of it over the last 3 or 4 months, we're finally getting to a place of learning what best practices may be, both for providers and patients. And so I think providers have learned that they need to have a designated spot, whether it's in their house or in their practice, where it's quiet, where they have good lighting. They need to make sure they have informed consent for telehealth visits with patients. They have to be prepared to deal with issues if the patient's technology is working, or if there's any kind of problem, and make sure the patient can hear them properly. So there's best practices definitely for the provider, including making sure that they properly document the visit. I don't know if there's going to be too much auditing against the reimbursement for these visits, but I would think you certainly want adequate clinical documentation of every encounter, no matter how you deliver it. And for patients, the best practice for their side is they need to kind of be educated. They need to have again a spot with good light, a strong internet signal. If we don't have a strong internet signal, a good broadband, nothing's going to happen, really. Patients don't need to be holding a phone that they're moving all around. It should be in a steady position. There shouldn't be a lot of background noise. And so I know the first time or two a patient uses telehealth, it's a new thing, totally. So it takes a little while for the patients to become comfortable also. So I think we're just at the place where we're starting to have some of these best practices. I know Rob is probably working and has a lot of insight into best practices on the provider side, educating the services that are available. It's a very exciting time. If the maybe one good thing that's come out of this horrible emergency has been the explosion in telehealth, and the benefits that were kept buried deep underground were forced to the surface. And now our job is to separate the wheat from the chaff. And I think that's hopefully what we've done a little bit today.
Thank you, Jim. Rob, to you for your final thoughts.
Yeah, I'll be quick. I want to thank Matt, you, and Carol, but also I learned a lot from Jim and Allison. It was a great discussion. It's a seismic change in how healthcare is delivered. We hope that it doesn't end with the pandemic. I think we are waiting to see what the payers are going to do, certainly Medicare, but also the commercial plans. We think it's a positive change. We think it's a change to stay, but it's all going to be driven by data. And I know there's a couple of bills in Congress calling for CMS and other agencies, GAO, to conduct studies, reports, finding out what the impact of this will be. I think it will be positive. I think a lot of us here have talked about that. I think it's going to drive costs down overall and provide better care and, frankly, better patient satisfaction. And I think younger patients are going to be expecting this. It's not going to be a nice thing to have. It's going to be, I want to have it. And so we'll see how things develop. Workflow is critical. Jim, you mentioned the word documentation. That is so important. We have to know what payers require, especially post-pandemic, when sort of the fire goes out. Now we're back to normal. We have to know exactly what payers want. My last sort of point will be, one of the challenges has been the vast differences between commercial health plan telehealth policies. It would be nice to come up with a little more standard approach to all of this, make it a little bit easier, just like other areas of healthcare, like prior authorization and all the other hassle factors. But the more standardized things are, the easier they are and the cheaper they are. So I'll leave with that. Thank you.
All right. Thank you, Rob. And Allison, you get to bring us home after leading us in.
Well, thanks for having me. Thank you for the great discussion today. I learned a lot, and it's fascinating to hear these perspectives. Since we're just about out of time, I would just encourage everybody, if telehealth is an option for your next visit, give it a try. I think once people utilize and have a telehealth visit, that stigma is gone and you can really see what it can be like. It differs by provider or platform or things like that, but really kind of breaking the ice and getting your first visit, see if that's an option for your next modality. I had a visit I needed and I just called the provider and I said, "Are you guys doing telehealth?" They said, "Yep." And that's how I had my visit. So I encourage folks listening today to give it a shot for your next healthcare visit if it's an option. And thanks again for having me.
Yeah, no, thank you very much, and a great call to action. And thank you all three of you again for the great discussion. Thank you to everyone who attended, and we will be signing off now.
Yeah, I echo all of that. Thank you, Allison, Rob, Matt, Jim, of course. Fabulous conversation, and thank you to our attendees. We'll be getting a recording out to you by the end of the week, and stay tuned for our next upcoming virtual panel. Look for your email. Again, thank you to everybody. Stay safe and healthy.
Stay
Thank
safe
you.
and strong. Thank you.